So at this point, I'd like to turn it over to my colleague, Cassie, who will be moderating the first open forum. So because of the challenges in time zones, we are actually doing an open forum first with our keynote speakers from this morning. So I'm very happy to see Professor Pim Keisters and of course my colleague Ken with us now here at the call. And also just a quick note that after the first open forum, we'll also do our group photo. So we'll just do a screenshot of everybody in the call, just to make sure that we capture this moment for documentation. So over to you, Cassie, for our first open forum.
Thank you very much, Jason, and welcome everyone to our first speaker forum and the first opportunity for all of you joining us to interact with our speakers. So very, very exciting. As Jason said, my name's Cassie. I work with him in the mental health unit at the WHO Western Pacific Regional Office. And it's my very great pleasure to introduce our two keynote speakers from this morning, who are now with us in a slightly more friendly time. So hoping you're caffeinated and ready for questions. We have Professor Pim Cuijpers from the Vrije University in Amsterdam and Dr. Ken Carswell from the Mental Health Unit at WHO headquarters in Geneva. So please, if you've all been sitting on your questions all day, please put them into the Q&A box or the chat box, and we'll try to get to as many of them as we can in the next 20 minutes or so. So while people are thinking, I want to start by thanking both of you for being here with us. Thank you for really interesting presentations this morning. They are very thought-provoking, and I'm sure people will want to ask you a lot of questions. I might kick off with a question of my own. You both talked about settings for implementation in your talks from slightly different angles, both the opportunities for implementation in a wide range of settings, but also opportunities for embedding interventions within a mental health service or a step care model. So I'm wondering what you think the most promising areas or settings for implementation of digital interventions are outside the traditional health or mental health systems, and as well whether there are particular risks associated with those settings that we should be keeping in mind. I might put that first to Professor Cuijpers and then Ken, if you want to answer as well.
Hi, thank you. Good morning, everyone. I hope you like my presentation. It is a bit weird that it's all digital and that I join in later in person, but I would have liked so much to be there in person and to talk to you in person about these things. But unfortunately, that's of course not possible. Well, about implementation, I think that's a very big question, first of all, because I mean, technology is entering almost all areas of life. And that means that the possibilities to use technology in daily life are there. They are so big and so large. And I mean, it's I don't know how it's in other countries very well, but in Holland, internet interventions are already used a lot in healthcare systems. And actually, the mental health care institutes, they get paid extra when they do more online. And of course, this has changed even further because of the COVID, because of the pandemic. But if you think outside the regular services, I think it would be very useful to think of services that are not related to a physical office, so to say, because you can offer online interventions regardless of where you are. And you can offer, and in some countries they have these kind of services, like in Australia, in Holland, there are a few of these services. In Sweden, these services already exist. But you could organize them internationally, starting with unguided interventions for common mental disorders, which are translated in as much languages as possible. These unguided interventions are not as effective as guided interventions, but they could be a first, how should I say that? A first start of mental health services in low and middle income countries that do not have the resources to start with a full system of mental health services. And then when you have this basis of cheap, unguided interventions, you can build guided interventions, and you can build other interventions in primary care or whatever, but you can use digital services as a basis for developing other mental health infrastructure things. Yeah, that's, well, I mean, I could talk all day about this, but I won't do that because I'm sure Ken has also a lot to add to this.
Great, thanks, Pim. And thank you, everybody. And yeah, thanks for the opportunity to talk. I think I would echo Pim's sentiments that, yeah, it was a shame not to be there in person, but it's good to have this discussion now. So a couple of things to add. I think I would agree completely with what Pim's saying around unguided interventions, and that being a first step. And that's something we're now looking we're exploring at WHO. How can we look at releasing step by step in some form of unguided way for wider use? With respect to the sort of the other areas where it could be used, I suppose for me the digital interventions don't necessarily need to sit within just the health system. So the health system is obviously a very good place for them to sit, but I'm also sort of thinking about child protection systems, social care, other aspects like that. And as Pim was saying, the ability to run these interventions from a centralized location. So for example, within a country, and having a team of e-helpers to run that from there could be done in a range of different settings. The one I think you asked Cassie about risks, and the one thing I'd sort of be thinking about is just that there needs to be ideally some sort of joining up. So for example, some sort of system there for responding to people, particularly if you're offering guided self-help, but some way of responding to people who might indicate risk of harm, or people who might need other services or might need other forms of support. But there are very innovative and interesting ways to do that could be fitted within different countries and contexts. So if that was in place, I would imagine there'll be a range of different areas, a range of different platforms where those where such interventions could be considered. Thank you.
Thank you so much.
Can I add one more risk?
Of course.
I mean, if you develop digital services, I think that's very useful, of course, and it will allow a lot of people to use mental health services. But it can also be used by governments to say, okay, we've done enough for mental health, and we organize these services. We leave that to the technical people and the mental health people, and then we're done, and we don't have to organize other services. And I think that's a serious risk we have here. And we have to make clear that digital services are not the only thing that are needed to improve mental health care in countries.
Thank you so much to both of you. I think those are really, really important, and particularly the risks to keep in mind. I remind all of you participants that if you have questions, please put them in the Q&A box or the chat box. We're very keen to hear from you all. I have a couple of questions that have come through. So the first one is to Ken. Ken, any suggestion or lessons learned about what the minimum requirements or skills or knowledge needed for a person to be a helper? Because you had mentioned that helpers could be non-professional lay people.
Sure. So in most of our WHO interventions, both digital and non-digital, we talk about non-specialist helpers. I suppose really the requirements will vary depending on location, but normally we're thinking of people who have some level of education and level of literacy. So maybe they've completed secondary school education. Often in the research trials that we've done, so you know, as we were talking before and as we were hearing before, implementation is a bit of an issue. So with a lot of the research trials we've done, helpers have had either sort of secondary school education or perhaps higher. So for example, undergraduate level education. I think it depends very much on the intervention and the setting. But one really great resource we have in many countries is many people who are looking for training, support, internships, things like this in the field of mental health. So they maybe are interested in mental health and have completed college level education or university level education. And we have quite a few people like this. We also have people maybe who are doing some form of training in social work care or clinical psychology or something similar like this. So these people might be ideal both in two ways, because firstly that they may already have quite a good level of education and a good level of sort of what we call foundational helping skills, but also the training organizations might also be looking for practicums or internships where they can develop some clinical skills. So sort of combining these two things, combining, for example, a social work or a psychology course and some sort of digital health intervention where people are helpers might be quite a nice way of addressing two issues at once. And it's something that we're starting to explore. So with our Scale Up and Step by Step in Lebanon, we're the colleagues there are working with a emotional support helpline called Embrace. And we're working with volunteers, and I think a lot of the volunteers there are people who are looking to go into health or social care professions. And then we'll also start probably exploring if there are any relationships that we can make with universities to have some form of training internship model.
What is important to realize when you think of who can deliver these interventions is that they do not have to be well-trained psychotherapists, clinical psychologists, psychiatrists, because they don't apply a treatment. The patients, they apply the treatment to themselves. And how they can do that is explained in the intervention. And so that means that the coaches, or however you call them, only guide people through while they are applying the treatment to themselves. And that's something completely different than a therapist who delivers a treatment. And I think that's very important when you think about who can do that. And I think the United Kingdom has a very good example here with the IAP program, where they train psychological well-being practitioners who are also not fully trained psychologists or whatever. And in Holland, we are, for example, integrating that training into our clinical psychology program so that people who are ready can deliver these interventions without becoming a fully trained therapist who needs a lot of training for several years.
I'd just like to add to that, Cassie, just briefly. I suppose that the other important thing to mention is we have the helpers and their background and skills, and then really important is the need for supervision and support, and that is something that does need to be considered. So helpers require that support, both with more complex issues that might come up, but also for their own well-being and self-care. So that's an important aspect that needs to be there as well.
Yeah, thank you. Look, and that leads beautifully into the next question that we have here, which is directed at you, Professor Cuijpers. In your speech, you mentioned guided treatment. Is there a common definition or convention about what guided treatment actually is? What is required in the guidance? And is there a sort of a threshold level, I suppose, for how much support is provided?
Well, these are very good questions, but they are also empirical questions to which we really don't know the answer. But we do know that if there is some human support and patients could connect to a person, then the effects are there. And whether you deliver the treatment then individually or in groups or through the internet or whatever, we don't have an indication that these effects are different. So I would say until now that you need some kind of connection with a human in order to realize the effects of an intervention. And what's the minimum of that? I don't know. I mean, I would say that as a patient, you have to connect to that person, because that's what I would think is the most important thing. So if you only see a person once and you will, after that, you will do the intervention completely on your own, I think that's not enough. So you have to see somebody while you work through the self-help intervention. And yeah, I would say, well, if you spend 20 minutes or 15 minutes per week on an email to make the patient feel connected to you and that you are there to help her or him to go through the intervention, that should be enough. But maybe we can even further reduce that. And these, as I said, these are empirical questions to which we do not actually know the answer.
Lots of interesting research questions for the future for implementation research. Okay, we have a question for Dr. Carswell. The coding that was used to build specific software is owned by whom? For example, Step by Step in Lebanon, is it owned by the WHO or by Lebanon government or others?
Very good question, and something that I've been racking my brain about for quite a long time now. So Step by Step and the intervention in Lebanon, the software code was actually built by colleagues at Vrije University Berlin, and huge thanks to Sebastian who led a lot of those efforts and coordinated that work. And it was built on a software platform that the university developed for another project called Strengths, where they were also testing Step by Step in other settings. So we've been running the research. We ran the research on that code, and as I understand, that code is open source. But it's a big problem, and it's a problem we've been struggling with it and thinking about at WHO, because obviously we have Step by Step. We've completed some trials on it. We're very happy with it. But if we want to release it and scale it, there is a barrier, because I don't feel we can say to different countries and organizations, here's all the content, please go ahead and build a system yourself. So we're actually just started work on an open source system for the delivery of Step by Step. So in terms of who would own that, it's something we're going to work out in the coming months and over the course of this year. But it would be open source, so it would mean that a country could take the code and use their own implementation. Or there might be a system where, for example, we can run multiple different versions of it on one platform with the data owned by the country and the code being open source, but maybe run by a technology provider. So we're trying to solve this, and it's quite complicated, because then you need to keep the software updated. You need to find funding to keep it updated. Even if a country runs their own implementation of it, There will need to be expertise to ensure that it runs. But I suppose I mean, really in summary, we could say that we're aiming for an open source software. The content of Step by Step when we release it will be under Creative Commons. So that means it'll be free to be used and adapted, because that's how we release things now in WHO. And then the data would very much belong to the implementing organization or country in line with their own data protection laws and rules. So hopefully I'll have a better answer for it in a few months' time.
That was a pretty comprehensive answer, I think. So thank you for having a go. Okay, we have quite a few questions now. So at the keynote this morning, it was mentioned that certain factors are associated with more success for non-guided interventions. What are some examples of these factors? I think that might be directed at you, Pim.
Yeah, you should read our paper in JAMA Psychiatry earlier this year, where we did an individual patient data network meta-analysis in which we have all the primary data of trials on unguided and guided interventions. And so because we have the primary data, we can look who benefits from the interventions. And so there is a website where you can just fill in the characteristics that are relevant for the outcome. And then you can see for each patient whether they benefit from guided or from unguided. What is most notable in this is that we found that in lower severity of depression, there is no significant difference between guided and unguided interventions. So that means that if you want to implement internet interventions, you can separate, well, the more severe people from the less severe people. And for the less severe people, unguided interventions are just as good as the guided interventions. Yeah. Is that a question? Yeah, it's the paper in JAMA Psychiatry, and my colleague Irini Kariotaki is the first author of that. I don't know if I talked about this extensively this morning in my lecture, but the paper is out now in JAMA Psychiatry.
Excellent, thank you. And I think I'm sure that others were quite impressed, as I was, at that tool that that allows you to put in characteristics and demographic information. Look, we have a few more questions, but we are running over time, and I see that all our speakers for the next panel are with us now. So we might have to leave it there. We do have time for more questions later this afternoon after the next panel. So I'm going to leave it there for the moment, but I wanted to thank you both, Ken and Pim, for being with us and for answering those questions from the audience. That was very, very interesting, and I think everyone will have got a lot out of it. So thank you.